Stephen Kralik, who is an assistant professor of radiology at Baylor College of Medicine, to discuss the neuroradiological findings in acute flaccid myelitis.
Thanks. Hi, my name is Steve Kralik. I'm an associate professor of radiology at Texas Children's Hospital. I'm going to be talking about neuroradiological manifestations of acute flaccid myelitis. So we're going to talk about imaging patterns in acute flaccid myelitis and the imaging differential diagnoses. And to start with, I want to talk about some of the, move this out of the way. Sorry. There we go. I want to talk about the normal spinal cord imaging pattern. So we typically run T2 and T1 weighted imaging, and basically a T2 image, the fluid is really bright. So that's the easy way to know it's a T2, and a T1, the fluid is dark over here. On a T2 image, the spinal cord is sort of an intermediate signal intensity and relatively homogeneous, as you see here. So this would be a normal T2 appearance of the spinal cord. We really like the axial images as well, because that kind of tells us where exactly any abnormality may be in the spinal cord. So that's what you're seeing here. And the cord, again, has a relatively intermediate signal intensity pattern. And at different levels, the spinal cord may have a different shape depending on where you are in the spinal column. On the T1 weighted image here, we'll give contrast, and we're looking to see if anything shows up bright on the spinal cord or cauda equina, as you see here. So this is kind of, you want to burn this in your brain as what normal should look like. So nothing bright in the spinal cord on the sagittal or axial, and then nothing bright showing up on the T1 post contrast. Some terminology that I also have to make sure that we're all clear on, because I'm going to use these very frequently, is something called longitudinally extensive cord signal abnormality, or longitudinally extensive pattern. Means that it involves more than 2 vertebral bodies in length. So this T2 signal pattern extends for more than 2 vertebral bodies in length. Whereas over here, this T2 pattern is really short. It's short craniocaudal length, about 2 or a little bit less than 2. So if we look at also on the axial, we're going to talk about a pattern called predominantly gray matter or central gray matter pattern. So we know from anatomy, the central gray matter is sort of like a butterfly or H shape in the central spinal cord. It's going to be predominantly like this. So if we see something that looks like that, that's abnormally bright in the central cord, looking like a butterfly or an H, we're going to call it gray matter predominant or gray matter involvement. Okay, so I want to just, before we start, talk about how AFM imaging does have some classical patterns that we'll see, but it's also a spectrum. So I don't know how often you go into a grocery store, but maybe this year I finally realized there's something, a mix of a plum and an apricot. So sometimes AFM basically has a plum-like pattern, which is very classic, but sometimes there's other features that might look like some other diagnoses get blended in with what we want to be AFM and turns into our pluot. So we have to be ready for a little bit of variance in what the classical patterns should be, but I'm going to show you predominantly a lot of classical patterns today. So the AFM case 1 that I'm going to show you is a 5-year-old male presented with acute right upper extremity weakness, had 1 week prior history of fever, upper respiratory symptoms. His CSF white count was 154, had normal glucose, mild elevation of protein. I'm going to show you the initial and 11-day follow-up MRIs. Now, a lot of these cases, I should point out, have follow-up MRIs because in the beginning, when we were seeing these cases, we didn't really know what this was. So currently, we don't do as many follow-ups MRIs when we have a diagnosis of AFM. But in the beginning, we didn't really know what was causing a lot of these problems. And so we had more follow-up MRIs because of that. So what we're seeing here is a longitudinally extensive T2 hyperintense signal involving the spinal cord. So I'm just going to go back, show you again. Spinal cord should look like this, nice and diffusely gray, kind of intermediate. Our case 1 has abnormal T2 signal. It's longitudinally extensive. It's involving cervical and thoracic cord. We go to our axial images, which we like, and we're going to see that kind of H-shaped pattern involving the gray matter in both the cervical levels and then even into the thoracic cord here. Now, we also saw that the abnormal T2 signal extended into the dorsal pons, as you see here, and dorsal medulla here, which we're seeing on the axial images. So this should also look normally like this signal intensity, but it's too bright back here and too bright back here. So we have something involving posterior medulla and pons. Now, when we look at the 11-day follow-up MRI, what was kind of interesting was that in the cervical levels and really the rest of the thoracic cord, we saw this pattern of kind of this H-shaped pattern turn just into small dot-like areas, more right more than left in the anterior horn area of the gray matter. And also when we went down to the cauda equina, where we previously had no abnormal enhancement in the cord or cauda equina, we started seeing new enhancement in the anterior roots of the lumbar and sacral vertebrae levels. So in summary, we had a longitudinally extensive pattern. It was mildly expansile, but not expansile as much as we think of a tumor, for example. There was predominantly gray matter pattern that evolved to an anterior horn pattern. And then there was delayed cauda equina enhancement. So this was a case of AFM. Case 2, we had a 4-year-old male presented with fever, vomiting, generalized weakness, more significant recent involvement of bilateral upper extremity weakness. They had hyporeflexia. Their CSF white count was 35, normal glucose and protein. They had a brain MRI, which was performed before the spine was normal. The MRI was performed 3 days after symptom onset, and then I'll show you a follow-up at 10 days. So what we see here is kind of subtle. If you look at the spinal cord, this is more normal intensity pattern, and we're starting to get a faint T2 hyperintense pattern through the cervical cord, through here. Again, it's sometimes very difficult on the sagittal. It can almost look pencil-like in its intensity through here. When you go to the axials, it's a little more apparent. There is a little bit of a central gray matter H-shaped pattern here in the spinal cord. On the follow-up imaging, where there was no previous enhancement of the cord or cauda equina, again, we start seeing cauda equina now enhancing. So this was longitudinally extensive. We saw through the cervical cord, no expansion, involved the gray matter. There was enhancement on delayed follow-up of the cauda equina, and the brain MRI was normal. So this is usually what we will often see in normal brain MRI. Again, we might see that posterior medulla or pons be involved as one pattern. Case 3 is a 5-year-old with acute onset left upper extremity weakness. At 10 days prior history of upper respiratory symptoms of cough and fever. The CSF white count was 41, normal glucose and protein. They had a normal brain MRI. And here's the MRI at presentation. We're seeing really a T2 hyperintense pattern that's in the central part of the cord again. Here we go to the axials. The axials are really better for defining where exactly precisely it is. So if I had one sequence to look for AFM, I'd want an axial T2. That would be the easiest one. So here you're again seeing that H-shaped pattern, maybe just some faint hyperintense signal more in the dorsal columns here. When we go to the post-contrast imaging, unlike the last 2 cases we saw, we're starting to see very faint enhancement in the anterior horns here on this MRI, where in the last couple ones we didn't have that one. So we have longitudinally extensive, again, mild expansion, the cord is just slightly expanded. We have a predominant gray matter pattern, maybe some faint white matter in the posterior. We have these anterior horn cell enhancement here and here, and then we had a normal brain MRI. So this case fit in again with the AFM pattern. Okay, case 4, 6-year-old female, bilateral lower extremity weakness, unable to walk. Their CSF white count was 10, normal glucose and protein. Brain MRI was normal. MRI done 6 days after onset. So kind of telling you all these little time frames, but a lot of times what we're seeing is a combination of when they present and how bad the inflammation is in the spinal cord of why we see sometimes it look a certain way. So here we're seeing a thoracic cord, and these sometimes are notoriously hard to image well, and that's what I'm showing you here is some of your scans might look the same. This has some abnormal T2 signal in the kind of mid and lower thoracic cord. You can see this kind of, again, I was talking about that pencil-like T2 hyperintense signal that you'll sometimes see. You always want to verify this with an axial to be sure that it's not some artifact that sometimes is pulsating through the patient's chest. So there's cardiac and respiratory motion that sometimes you'll see if you really look closely, there's little arc-like lines and it just happens to fall through the spinal cord. Use your axials to confirm whether that is real or not spinal cord signal abnormality. On this one, it was that classic butterfly-shaped pattern through the thoracic cord. There was no enhancement this time on our axial T1. Here's our of the spinal cord, but when we go down a little bit lower into the cauda equina, here's our spinal cord. What you want to do is use your spinal cord as an internal reference. So the intensity of the spinal cord should be similar to the cauda equina, and this is not doing that. The cauda equina are just a little bit brighter than spinal cord, telling us there is some enhancement in the spinal nerve roots. That's what we're seeing here. So some mild cauda equina enhancement. was present. So we had, again, longitudinally extensive. This one was more thoracic. We've seen the last three be more cervical involvement, which is more typical. This was involving classically the central gray matter. There was no spinal cord enhancement, but we did see cauda equina enhancement, and then the brain MRI was normal. Case 5, I have just a few more to show you. So these are sometimes what happens is you can't get the whole spinal cord in one shot. So I have the upper part here and a little bit more lower down here. But we are seeing, again, this abnormal appearance of T2 hyperintense signal dorsal medulla. We're seeing cervical medullary junction, central cervical cord upper here. And then central cord, we're seeing it through here in the cervical spine. And then we need to figure out, is this bright signal also abnormal in the cervical, in the thoracic spine? Indeed, on the axials, it was showing the classic H-shaped pattern or butterfly pattern in the cervical spine, same within the thoracic cord. So we know this was really longitudinally extensive, going from medulla basically all the way down to the conus. And here was that dorsal medulla abnormal signal. So very longitudinally extensive, classic central gray matter pattern. Even had the dorsal medulla and pons pattern in the brain that we like to see for AFM. The 14-day follow-up MRI, look how amazing this T2 signal abnormality on this patient actually resolved in the cervical cord and thoracic cords. There's no more cord signal changes. But lo and behold, we see this again, development of cauda equina enhancement that was new compared to the initial MRI. So sometimes what happens is that this pattern, it'll evolve to completely go away. Sometimes on that intermediate follow-up study at 2 weeks, sometimes you will just see only the anterior horns left. Okay, I think one or two more cases to show you. So this is a 5-year-old presenting with right arm weakness and pain and weakness, recent upper respiratory infection, had a CSF white count of 45, normal glucose and protein, normal brain MRI. MRI at 4 days after onset, here's what we have. So if I was just looking at this sagittal T2, I might almost want to call it normal, but might catch my eye as this faint little, again, pencil-like T2 hyperintense signal through here. That's sometimes how very subtle this is. So I'm going to jump right away to our axial T2s and show you that there's really more predominant anterior horn T2 signal intensity than there is kind of more posterior in that gray matter region. There was minimal enhancement, I think we're seeing right here. But if you only have a sagittal T2 or a sagittal post-contrast, it's going to be very hard in some cases to make this diagnosis. The axial T2s is kind of a great example of why I think it's so important to have good axial T2s. And if this is the only sequence you get, this would be the one you want. So longitudinally extensive, mildly expansion, anterior horns predominantly were the what's showing up here. There was just some faint enhancement in the anterior horns. I'd have to reference that to the axials to be sure. I didn't show you the axial on this one, but it was there. And then the brain MRI was normal. Okay, last AFM case, and we'll just look at some differential diagnoses. This was a 10-year-old that presented with bilateral upper extremity weakness. Oops. It had CSF white count 23, normal glucose, mild elevation of protein. This is the MRI after 4 days of onset. So this is one that probably all of our med students can appreciate as abnormal. Going from the cervical spine into the upper thoracic cord, you see this T2 hyperintense signal. It's longitudinally extensive. This is a lot more than I've shown you on a lot of the other cases. When I go to the axial images, there are a lot of areas that are more central gray matter predominance, as you see here. You see here, this is starting to get smudgy in the dorsal columns, a little bit in lateral. As you come down even farther, probably is somewhere through this level. You're seeing now it's kind of vague. Is it gray matter predominant? Is it white matter predominant? This is one of those cases we often see, that pluot type case I'm telling you about, where a lot of the levels it looks like good for AFM. Then you start getting here and you're like, is this AFM? Not really sure. This one we felt was AFM. Also, the other thing that helped us was this anterior horn enhancement pattern that we saw. Don't typically see that with other diagnoses. But this is certainly one that might blend into some of the differential diagnoses I'm showing you later. But longitudinally extensive, moderate expansion, predominantly gray matter, but kind of questionable in some areas. Anterior horn enhancement, brain MRI was normal, which is really helpful. If we saw something else that might sway us in the diagnosis. This one, as a radiologist, I'm probably going to give a differential diagnosis for sure, and we'll go over some of those next. But in my summary, what I've shown you kind of repetitively in just different little twists on it is longitudinally extensive, very common to have that, gray matter or gray matter predominant, non-enhancing, or sometimes you get the anterior horns enhancing. For the spinal cord, cervical more than thoracic, dorsal pons and medulla are classic areas that it can involve. In more of the subacute and chronic time frame, so talking like 5 days, 7 days later, we'll start to see really only maybe just anterior horns show up on the T2 pattern as a possibility. And these cauda equina like to enhance in that more subacute and chronic phases. So this was just the patterns I'm showing you, that central gray matter or anterior horn involvement. But sometimes just kind of very sharp pencil-like look on the sagittal, which can be very hard to see, and kind of dorsal pons and medulla pattern here. So let's look at some differential diagnoses that were that may mimic AFM or vice versa. This was a patient that had, oops, let me try to get this out of the way. Can't get that out of the way. Okay, this was a 15-year-old who had acute upper extremity weakness. Looks like his white count was a very acute onset of upper extremity weakness. White count was 1, normal glucose and normal protein. And so what we see is that we have again a longitudinally extensive T2 hyperintense signal from the cervical to upper thoracic cord. So that's kind of looks like our AFM I showed you, very pencil-like and sharp. We go to our post-contrast imaging, there's no enhancement that we're seeing. We go to our cross-section T2, looks really good for that butterfly-like pattern. So we're thinking, okay, feeling good about AFM. We started to do more diffusion-weighted imaging to try to see if there's any differences in AFM from other diagnoses. This one had what looks like abnormal hyperintense diffusion signal. So this one, longitudinally extensive, no expansion, central gray, no enhancement, diffusion restriction, looks like it could be AFM. We don't know about what AFM does on diffusion restriction. We know what another diagnosis does, so we were worried about something else. And we did a follow-up MRI approximately 2 days later to see how this transitioned, because we were a little bit wondering how this might look. Axially, on the axial section, you can see how much it dramatically blew up in that same level where it was very sharply defined, now is more diffusely the whole transection of the spinal cord. We still had that diffusion restriction as well. So this rapidly changed. I didn't show you any cases that showed that degree of rapid change in the T2 pattern. In fact, most of them I showed you actually got better. So this was something different than AFM does, and I'm going to show you what we keyed in on also at the very beginning was if we look very closely at this level of C6-7, there's, if you look at the vertebrae here, the disc spaces here, there's kind of a black line that kind of marks the whole disc space. Here, that's disc space is interrupted. So that's something called an annular tear. Now that means potentially there was a disc injury. And so if you think there may be a disc injury and you're seeing something in the spinal cord, you probably want to think of potentially the diagnosis of acute spinal cord infarct. And that's what we ultimately felt this was that transition from more central gray matter rapidly to the whole cross section of the cord fit more with acute spinal cord infarct. And again, we don't know really about what AFM does on diffusion weighted imaging, but it's something that we're looking into whether or not that can help distinguish those two diagnoses. Okay, this was a 10-year-old boy, and he had lower extremity weakness. There was a sensory level, my screen's blocking it, but he had decreased sensation and pinprick in the mid-thoracic level, but intact position vibratory sense. He had a CSF white count of 124, normal glucose, elevated protein. Here we're seeing that longitudinally extensive transverse, longitudinally extensive cord signal abnormality in the cervical and thoracic cord. So we've seen that before a lot. Now we go to the axials and not clearly gray matter predominant. So it's definitely involving gray matter, but probably too much. This is not really that butterfly or H-shaped pattern. You come down here, maybe it's getting closer to that, but really not easy to call that a central gray matter predominant pattern. You go to the post-contrast, there's very faint enhancement, several areas in kind of anterior and posterior cord. His brain MRI was normal. This was longitudinally extensive, had mild expansion, involved really a majority of the cross section of the cord at several levels. We couldn't really give it a gray matter predominant pattern. And there was some mild patchy enhancement, really more kind of patchy throughout the cord, not specifically the anterior horns. This patient was diagnosed with a transverse myelitis. Also, the clinical history was very important for our physicians, really with that additional sensory and urinary issues, calling it transverse myelitis instead of AFM. This is next case is a 10-year-old with lower extremity weakness, hyporeflexia, CSF bite count was 59, had normal glucose and protein. This is a one single image, but I'm going to tell you this is normal. So if you look again at the T2 pattern, it looks nice and homogeneous. So this person had a normal spinal cord. So you might say, why are you showing me this? Well, if you actually go to the post-contrast imaging, there was cauda equina enhancement both anteriorly and posteriorly. As you see here, here's the spinal cord. So the cord should be the same intensity as the cauda equina, and this one is clearly not. So this is enhancement in the cauda equina. So we do have one imaging overlap of AFM with cauda equina enhancement, but we don't really have any of that spinal cord pattern. So brain MRI was again normal. So normal spinal cord, but abnormal cauda equina. This was Guillain-Barré. So this is what I would like to see for Guillain-Barré, really no spinal cord abnormality. You can have some cranial nerve enhancement in Guillain-Barré, Miller-Fisher variant, but really that's kind of it. You shouldn't have that cord signal pattern that we see with AFM. Case 4, 11-year-old with 2-week history of difficulty walking, hyperreflexia, and weakness. CSF bite count was 2, normal glucose, mild elevation of protein. So back to our longitudinally extensive cord signal abnormality from upper cervical cord into the thoracic cord. Our axial pattern not really fitting that gray matter pattern predominant. So we have even more hyperintense areas laterally, but it's really kind of almost the whole cord at multiple levels. So we don't really want to call this AFM, I think. Again, patchy enhancement, both anteriorly here, but also posteriorly here. When we went to the brain MRI, very subtle findings showed that T2 hyperintense signal in the optic chiasm on both sides. So now we are seeing longitudinally extensive pattern, mild expansion. Majority of the cross section of the cords involved. There's some patchy enhancement, but now our optic pathway is abnormal. That's a nice finding for something else called neuromyelitis optica. What we might also see in neuromyelitis optica would be medial thalamic involvement or hypothalamic involvement. The one, again, imaging overlap with AFM is it does like to involve kind of dorsal pons and medulla here, but not really typical to show that optic neuritis, which you might see with neuromyelitis optica. Case 15, our last thing in the differential diagnosis was a patient with upper extremity and lower extremity weakness and lower extremity numbness. So this patient has T2 signal abnormality in their spinal cord, but doesn't look longitudinally, at least contiguous. Some areas maybe here longitudinally extensive, others sort of look short segment. So this patient on the axials, not really completely a gray matter pattern, really not close to that, more transversely here, part of the posterior here. We do the post-contrast imaging, nothing showing up there. So this was really a combination of short and long segments that were involved. There was mild expansion. It was really too heterogeneous cross-section in the cord to call it acute flaccid myelitis. There's no enhancement. This patient had anti-MOG antibody, so this was a myelitis due to anti-MOG antibody. Similar things we see, the reason I kept harping on normal brain MRI, these other things might show these confluent areas in the brain, like the basal ganglia or white matter, or kind of multifocal white matter, as you see here. These really large confluent areas of anti-MOG, and then again, potentially an optic neuritis as well. So brain MRI is very helpful for looking for other findings that would push us away from AFM. So in my summary, AFM really uses that clinical history of that acute flaccid weakness, longitudinally extensive cord signal abnormality, central gray matter, or maybe just an anterior horn pattern, usually cervical more than thoracic, no cord enhancement or just maybe mild in the anterior horns. You can see that delayed cauda equina enhancement. Differential diagnosis, here's a couple major ones: acute spinal cord infarct, transverse myelitis, Guillain-Barré, anti-MOG, NMO. Sometimes we also see a very similar pattern, especially with Guillain-Barré, of West Nile virus can cause a very similar pattern. And then poliovirus is the one that classically you hadn't seen for many, many years, but can show that anterior horn involvement as well. So that might be something that we need to think about more recently, as we've heard about recent cases of polio, could have a very similar pattern of AFM. So with that, I'm going to stop and thank you for your attention and have time for questions, I think.
Great. Thank you so much for sharing those images and the contrasting studies as well. That was helpful. If you have an initial scan that maybe is a little bit unclear for a patient where you suspect AFM, what's the best time frame to get a follow-up scan? That 5-7 days?
I'd like around 10 days roughly is a good number. 7 to 10 is pretty good.
Okay, and then you expect to see the abnormalities settle kind of then into the anterior horn on those follow-up scans.
Yeah, you could get that. Usually it's, the signal pattern is not going to get worse, number one. You'll have the cauda equina start enhancing. That's a good thing. So either the pattern of T2 in the cord either goes away or just left with the anterior horns. Could be either of those two. Okay,
great. It looks like we've got one additional question. So do the children who improve or recover completely have their MRIs normalized, or is there frequently some residual damage on long-term follow-up scans?
A lot of times that's based on their residual disability. So if they completely return to normal, they can have a normal scan. Yeah, but a lot of times a majority of them don't completely have some residual neurologic disability, and we can still see some anterior horn T2 signal changes. As you go farther and farther from the time of sort of the acute illness, it gets more and more subtle. It gets less and less easy to pick up.
Yeah, and I would echo that as well. I would say that clinically for the patients we see who remain more disabled, we are more likely to see residual changes on the spinal cord, but then sometimes we're surprised and they still have residual disability, but that MRI looks significantly better. So it's not always clearly predictable that way.
Right.
But sometimes can help you to know what the scan looks like in terms of talking a little bit about or thinking about prognosis. So that was super helpful. Thank you so much for reviewing those cases.
Great, you're welcome.